Welcome back. We are going to be starting into the trauma section of your emergency medical technician course. We are going to start out with bleeding and shock. Topics we're going to discuss in this section are going to be the circulatory system, shock, and bleeding. This first section will talk about the circulatory system. All right, so this diagram is going to show you the circulatory system. You're going to want to know how this is comprised and the components of the circulatory system. So make sure that you're knowing this, understanding it, and the basic functions of each component. So the main components of your circulatory system is going to be your heart, your blood vessels, and your actual blood. So first we'll talk about the heart. The heart is a muscular organ that lies within the chest behind that sternum. Its job is to pump the blood, which then supplies the oxygen and nutrients to the body's cells to provide a sufficient supply of oxygen and nutrients to all parts of the body, and then the heart must pump at an adequate rate and rhythm. So the blood is circulated throughout the body through three major types of blood vessels, which are the arteries, the capillaries, and the veins, which we will get into those. Next is the arteries. So the arteries carry freshly oxygenated blood away from the heart. They are under a great deal of pressure during the heart's contractions. So taking the patient's blood pressure is a means of measuring that arterial pressure. An artery has a thick muscular wall that enables it to dilate or constrict depending on the amount of oxygen and nutrients needed by cells or the organs that it feeds. Next is your capillaries. They are microscopic blood vessels. They are vital for the exchange site, and it's where they have oxygen and nutrients that pass through the capillary walls in exchange for carbon dioxide from the cells. Next is veins, and that the blood has been depleted of oxygen and loaded with carbon dioxide and other waste in the capillaries, then empties into the veins that carry it back to the heart. So the veins have a one-way valve that prevent the blood from flowing in the wrong direction. So blood in a vein is under much less pressure than blood from an actual artery. So next we're going to talk about the functions of the blood. So first and foremost, you got the transportation of gases, which oxygen is diffused into the blood at the alveoli in the lungs and is carried to the body's cells. So in a similar fashion, carbon dioxide is diffused into the blood at the body's cells and is carried back to the alveoli, where then it is offloaded and then exhaled. Next is nutrition. The blood circulates nutrients from the intestines or storage tissues, such as fatty tissues or the liver and muscles, and then that goes out to the other body cells. Excretion is when blood carries waste products from the cells to the organs, such as the kidneys, that excrete or eliminate the waste product from that body. Protection is where the blood carries antibodies and white blood cells, which help fight disease and infection. So the blood also contains platelets and clotting factors that work to control bleeding from the damaged blood vessels by forming the blood clots. And then last, you got regulation, and that's where the blood carries substance that controls the body's function, such as hormones, water, salt, enzymes, and chemicals. So the blood also plays an important role in regulating body temperature by carrying the body's heat to the lungs and skin surface, where it is then dissipated. Dilation or also expansion of the blood vessels increase the blood flow to the skin, which then increases the heat loss from the skin's surface. Conversely, constricting or narrowing of those blood vessels then decrease the blood flow to the skin, which then decreases heat loss or the core temperature, which can then be preserved. Perfusion is the adequate circulation of blood throughout the body, and hypoperfusion is the inadequate perfusion of the body's tissues and organs. So remember that perfusion is the adequate filling of the body's capillaries, which supplying the cells and tissues with oxygen and nutrients. Hypoperfusion results when some cells or organs do not receive adequate oxygen, which then causes a dangerous buildup of waste in the cells. In this next section, we're going to talk about shock. So I highly recommend reviewing the anatomy and physiology of the cardiovascular system because shock becomes much clearer when it's framed against a normal perfusion. So you want to be able to understand how the body compensates and how we can relate to their signs and symptoms. You also want to know how it works. And if you see the signs and symptoms, you can predict the level of compensation of your patient. So what is shock? Shock is the inadequate tissue perfusion. If hypoperfusion persists, cells and organs will die. So remember, shock is defined as an inadequate tissue perfusion. The pathophysiology of shock is four main causes. So it's the volume problems, the pump problems, the blood vessel tone problems, and obstruction of the blood flow. So I highly recommend reading and understanding all four of these causes. So with volume problems is hypovolemia. The blood is lost, or also known as an absolute hypovolemia. Plasma is removed from the circulatory system, which is then considered relative hypovolemia. There's not enough blood volume in the blood vessels, so then that's when your blood pressures fall. Both absolute and relative hypovolemia are called hypovolemic shock. Hemorrhagic shock is when you have a loss of blood. Next is pump problems. It is caused by a failure of the heart to pump the blood. It is usually related to a mechanical problem of the heart. Blood cannot be moved because of a drop in blood pressure, and it's categorized as cardiogenic shock. So if you have a pump problem, if it's a problem with your heart, it's considered cardiogenic shock. Next is blood vessel tone problems. All blood vessels dilate at the same time. Blood cannot fill the entire circulatory system. That is referred to as a distributive shock. Types of distributive shock are anaphylactic shock, neurogenic shock, or septic shock. Obstruction of blood flow. So that's when the blood flow is blocked. It is called obstructive shock. Caused by conditions such as pulmonary embolism, cardiac tamponade, or a tension pneumothorax. Next, you have your fight or flight. It's where the baroreceptors stimulate the release of epinephrine and norepinephrine. Your blood vessels will constrict, skin becomes cool and pale, becomes sweaty, and the kidneys produce less urine. You'll also have nausea and vomiting and an increased heart rate and contractibility. Next is compensation. That's when the body senses the decrease in perfusion and attempts to compensate for it. So compensation aims to restore the blood flow. So the regulation of volume, the vasoconstriction, and the cardiopulmonary response. It also has compensatory actions collectively called compensated shock. With your pediatric note, infants and children, efficient compensating mechanisms maintain blood pressure until half of the volume is depleted. You never want to wait for a drop in the blood pressure to identify shock in pediatric patients. And pediatric patients rely on the heart rate to compensate for shock. Fast heart rates are a key indicator that infant or pediatric patient is in shock. Next is decompensation. Compensated shock requires more fuel. So when the muscles run out of fuel for compensation, compensated shock then becomes decompensated shock. So the indicators for decompensation is the drop in blood pressure, mental status changes, slow heart rates, and slow respiratory rates. Irreversible shock and death. So prolonged vasoconstriction will lead to organ system damage and death over time. As organs begin to fail, irreversible shock begins, often resulting in apnea and cardiac arrest. During your patient assessment, you want to identify any underlying problems, recognize compensation, see and survey for any mechanism of injury, or illness, and then your primary assessment. With your airway, you want to correct any airway problems immediately. Next, to breathing, you would never want to allow a patient to become or remain hypoxic. Treat hypoxia with supplemental oxygen immediately. On to circulation, you're going to be checking the skin color, distal pulses, capillary refill time, and heart rate. Treat any problems found in the primary assessment immediately, and identify shock by trends in their vital signs. So remember, when a blood pressure starts to decrease, the pulse starts to increase, and respiratory rate increases, you can see that that is a trend that they're probably trending into shock. So make sure you're keeping a close eye on that. For your physical examination, you want to identify conditions that are associated with shock and do a history taking in the secondary assessment, focusing on the mechanism of injury, history of present illness, and their chief complaint. And then know what your signs of shock are. Treating shock. Treatment depends on underlying cause. The best way to resolve hypoperfusion is to stop whatever is causing it, which may mean surgery. So if you have a patient that is internally bleeding, they may require surgery. Even if it's external bleeding, it could potentially mean surgery. You want to use your primary assessment to identify any urgent interventions and use the patient assessment to identify treatment needs. Next is the deadly triad of trauma: acidosis, hypothermia, and coagulopathy. The treatment of deadly triad: you want to initiate transport to an appropriate destination, prevent hypoxia, prevent heat loss, consider shock positioning, and consider advanced life support. Also remembering to initiate rapid transport to an appropriate destination. Manage specific underlying causes of shock, manage the airway and breathing to prevent hypoxia, take steps to prevent heat loss, place the patient in supine position, and request ALS. In this next section, we're going to talk about bleeding. First, types of bleeding. Hemorrhage is a severe bleeding. It's a major cause of shock or hypoperfusion in trauma patients. It can be external or internal bleeding. All right, external bleeding. First is the arteries. That is the most major bleed that you can have. It's going to have spurting blood, pulsating flow, and bright red in color. You have to get this bleeding to stop immediately with pressure, with bandages, with quick clot, with tourniquets, whatever you have, stop that bleed. Okay? Next is a venous bleed. It's a steady, slow flow and dark red in color. This one you can typically put bandages on, put some pressure on it, and it'll stop bleeding. And then the last one is capillaries. It is slow, even flow. This one is, a lot of the times you can pop a Band-Aid on it and you're good to go. But remember, external bleeding or hemorrhage is bleeding that occurs outside of the body. It is typically visible on the surface of the skin. So external, you can see. So again, external bleeding occurs outside of the body after force penetrates the skin and lacerates or destroys the underlying blood vessels. Typically visible on the surface of the skin. How much a person bleeds is determined by the size and severity of the wound, the size and the pressure of the ruptured vessel, and the individual's ability to clot. So remember, arterial circulation is a high pressure system inside a thick, muscular walls, making it most difficult to control, where venous circulation is a low pressure system that is often lower than atmospheric pressure, which may suck in debris or air bubbles through that open wound. So the severity of external hemorrhage is directly related to the amount of pressure within those ruptured vessels. Massive hemorrhage is an arterial bleed, which is bright red in color, spurting with a heartbeat, and oxygen rich. Venous bleeding is dark in color than the arterial bleeding, less pressure than the arterial bleeding, and the volume of the blood carried by some veins can create immediate life-threatening hemorrhages. A junctional hemorrhage occurs when the appendages of the body connect to the trunk, so large arteries and veins are not well protected. An injury is likely to cause a massive bleed. Other external hemorrhages can be capillary bleeding, which is caused by superficial wounds to the surface of the skin. It's typically slow and oozing, and it just stops spontaneously. But remember, all bleeding does need to be stopped, and identifying the type of bleeding is almost irrelevant. If it's a capillary bleed or an arterial, you still have to stop it. However, it's what level of care you're going to have to give them that is going to show you what you need to do. So capillary Band-Aid, arterial, pressure, quick clot, tourniquets. So bleeding can be accelerated by underlying conditions. Prescription medications that are designed to limit the body's natural ability to form blood clots. Hypothermia affects the body's ability to clot, and external hemorrhage can usually be controlled by compressing the tissue around the wound. You always want to be sure that you're using precautions with external hemorrhage, so using your standard precautions, the gloves, the mask, the eyewear, and the gown, should be done on every single call that has that external hemorrhaging happening. And then, of course, be sure that you always wash your hands after every call. The hand sanitizer is fine for the time being, but actually washing your hands is the most adequate. So here's something to think about. How severe is the bleeding? Is it a massive hemorrhage? If so, how does that affect the priorities of the treatment? So remember, any massive hemorrhage is a rapidly life-threatening situation, so it must be the first priority. Stop that bleeding. You want to identify and control any massive hemorrhage within the first seconds of the primary assessment. Ensure that the airway is open and ensure that there's adequate breathing. So remember, bleeding control comes after airway and breathing assessment in the patient assessment. Standard precautions are still the first and most important step in every situation. You want to control any non-massive bleeding only after assessing and treating prior elements. You want to be aware of signs or symptoms of shock and do not wait for symptoms of shock to appear before beginning your treatment. Methods of controlling external bleeding include direct pressure, hemostatic agents, which is what we use around here is known as quick clot, wound packing, so if you've ever learned how to do the stop the bleed, which you will learn in the trauma portions, tourniquet use on extremities, and specialized compression devices for junctional bleeding. Controlling of the bleeding is essential to prevent shock. Uncontrolled bleeding can lead to patient death. Standard precautions are mandatory, and you want to observe standard precautions and infection control practices when cleaning up after the call. Strategies for external bleeding control. So first is direct pressure. You want to apply firm pressure to the wound with the palm of your hand or fingers. Hold pressure until the bleeding is controlled. Resist the temptation to apply layers of absorbent dressings. Once bleeding is controlled, bandage a dressing firmly in place to form a pressure dressing. Do not remove a dressing once it has been placed on the wound. Wound packing. Junctional areas present natural cavities that promote profuse bleeding. Direct pressure should be augmented by wound packing. And fill void spaces with hemostatic gauze. If you're doing pressure dressing, you want to place several gauze pads on the wound. Hold the dressings in place with self-adhering roller bandage wrapped tightly over the dressings and above and below the wound site. You want to create enough pressure to control bleeding. With hemostatic agents, it's designed to enhance direct pressure's ability to control the bleeding. Agents come in the form of an impregnated gauze or dressing. It's best suited for wound packing. This is what the Combat Gauze Quick Clot looks like. There's many different styles and brands out there, but this is just one of them. So know and understand what you're using. Next is tourniquet. It closes off all blood flow to and from an extremity. You want to use if the bleeding is uncontrolled by direct pressure. Use only on the extremity injuries and always apply between the wound and the heart. Remember that battlefield testing has shown that tourniquets are useful in bleeding not otherwise controlled, and that the average transport time of less than 1 hour does not pose a severe risk to the long-term outcome. So removing a tourniquet can dislodge clots that have formed, resulting in further blood loss. So once the tourniquet is put on, it should be left in place until you arrive at a surgical suite. Here's an indication of one of the tourniquets that you may end up using or may see. Just know that there are several different tourniquets out there, so make sure you know and understand which tourniquet you will be using within your department. Highly recommend reading your tourniquet handbook and also your protocols to be using that before you do apply one to a patient. So of course you always want to follow the manufacturer's instructions. Once applied, do not remove or loosen it, and attach a notation to the patient alerting other providers that the tourniquet has been applied. So with junctional tourniquets, it is designed specifically to control hemorrhage in the junctional areas of the axilla and the groin area. So something to think about. Is the current method of bleeding control working? Do you need to move on to a more aggressive step? And how would you evaluate this? So remember, you must always evaluate the efficiency of the current treatment before you escalate. So if you're doing fine with direct pressure, you can stay with direct pressure. But if it's continuing to bleed and you can't stop it, that's when you're going to move on to a more aggressive, like a tourniquet. Next is elevation. You want to elevate injured extremities above the level of the heart while applying direct pressure. Do not elevate if the musculoskeletal injury, impaled objects in the extremity, or the spine injury is suspected. When you are splinting, you want to stabilize sharp ends of broken bones. Or if you have inflatable air splints, those are always nice to use. Next is cold application. It minimizes swelling, constricts blood vessels, and reduces their pain. It's used in conjunction with other manual techniques. Special situations involving bleeding. So first is a head injury. From increased intracranial pressure, not direct trauma to the ears or nose. Stopping the bleeding only increases intracranial pressure. And you want to allow the drainage to flow freely, using gauze pads to collect it. Next is nosebleeds, or also known as epistaxis. You want to have the patient sit and lean forward. Apply direct pressure to flesh portions of the nostrils. Keep the patient calm and quiet, and do not let the patient lean back. If the patient becomes unconscious, you want to place the patient in a recovery position and prepare to suction. So remember, if the patient leans back, the patient can swallow blood, causing the stomach to become irritated and eventually cause nausea and vomiting. You want to begin hemorrhage control with direct pressure. Consider hemostatic agents to augment direct pressure. Consider the need for wound packing. Consider the use of a junctional tourniquet. If direct pressure fails or it is inappropriate, you want to apply a tourniquet. You're going to initiate rapid transport immediately and consider the need for ALS. Next, we'll talk about internal bleeding. Damage to internal organs and large blood vessels can result in a loss of a large quantity of blood in a short amount of time. Blood loss commonly cannot be seen. Severe blood loss can even result from injuries to extremities. Remember, sharp bone ends from a fractured extremity can tear surrounding vessels and tissues, resulting in severe bleeding. With your patient assessment, the mechanisms of blunt trauma that may cause internal bleeding include falls, motor vehicle or motorcycle crashes, auto pedestrian collisions, and blast injuries. Common injuries from penetrating trauma include gunshot wounds, stab wounds, and impaled objects. Remember that penetrating trauma is also a leading cause of internal bleeding. The amount of internal injury and bleeding is often difficult to judge. Signs of internal bleeding include injuries to the surface of the body, bruising, swelling, or tenderness of other vital organs. painful, swollen, or deformed extremities, and bleeding from the mouth, rectum, or vagina. Signs of internal bleeding can also cause tender, rigid, or distended abdomen, vomiting coffee ground-like substances or bright red vomit, dark tarry stools or bright red blood in the stool, and signs and symptoms of shock. When you're doing your patient assessment, bruising is one sign of internal bleeding. With your patient care, you want to maintain your ABCs, consider the need for high concentration oxygen, control any external bleeding, apply a splint if needed, take the steps to preserve body temperature, and provide prompt transport to the appropriate medical facilities. Remember, care for internal bleeding must include rapid transport to an appropriate facility. All right, let's go over the chapter review. Early signs of shock are often restlessness, anxiety, pale skin, and rapid pulse and respirations. If shock remains uncontrolled, the patient's blood pressure falls, which is a late sign of shock. Signs and symptoms of shock may not be evident early in the call, so treatment based on the mechanism of injury may be life-saving. Treat shock by maintaining the airway, preventing hypoxia, controlling bleeding, and keeping the patient warm. Almost all external bleeding can be controlled by direct pressure and elevation. When these don't work, apply a tourniquet if the bleeding is on an extremity or a hemostatic dressing if the bleeding is from the head or the torso. Emergency care for internal bleeding is based on the prevention and the treatment of shock. One of the most important treatments is early recognition of shock and immediate transport to the hospital. Remember, the circulatory system is designed to ensure adequate perfusion of body tissues. The classification of hemorrhage is directly related to the type of vessels ruptured and the pressure within the vessels. Remember, shock develops if the heart fails, blood volume is lost, or blood vessels dilate, resulting in inadequate perfusion. Signs of shock reflect the body's attempts at compensating for inadequate perfusion. The most significant treatment for the shock patient is early recognition and prompt transport to the hospital where the patient will receive definitive care. And remember that treatment of external hemorrhage includes progression through the following steps: direct pressure, wound packing, use of hemostatic agents, and tourniquet application. Internal bleeding is impossible to evaluate. The most appropriate treatment must be rapid transport to an appropriate facility. Questions to consider. What can I use for a tourniquet that will control bleeding but not damage tissue? And when treating a patient with shock, what should I do at the scene and what should I do en route to the hospital? So remember, you can use anything for a tourniquet as long as it's at least an inch or more wide. You can use a blood pressure cuff, you can use a belt, you can use a real tourniquet. So when you're treating somebody in shock, what should you do at the scene versus what should you do en route? At the scene should be only life-threatening conditions that should be taken care of, and then load and go if you're a transporting service. Do everything else en route to the hospital. Is a patient with pale, cool skin, tachycardic, and rapid shallow respirations in shock or just under stress? How will continuing an assessment help in making that decision? Just remember, if this is all the information that you have, you can assume that your patient is in shock. However, this is a possibility that they're just under stress as well. So to do your continued assessment will help in making that decision, asking additional questions, taking more vital signs, and so forth. Critical thinking. A patient has been involved in a motor vehicle collision. There is considerable damage to the vehicle. The steering column and the wheel are badly deformed. The patient complains of a sore chest. You note no external bleeding. The patient's vital signs are pulse 116, respirations 20, and a blood pressure of 106/70. How would you proceed to assess and care for this patient? So remember, key is to look at the respirations, which are normal at this point. His pulse is increased. A normal is 60 to 100, but his pulse is a little elevated. And his blood pressure for what he was just gone through is 106/70, which I would consider in the situation that would be low. However, you don't know what the normal blood pressure of this patient is.